Hi guys, welcome to my fertility Q&A series. I love my best friend and I just called her and she's going to join us right now. Dr. Catherine DeUgarte, I've known her for over 15 years. We've known each other since we were little embryos, and all we do when we hang out together is talk about fertility. And we're both very passionate and we take what we do very, very seriously. So I'm super excited to have her on. And for those of you who are joining for the first time and don't know about the Egg Whisperer School, go to eggwhisperschool.com, and I have an IVF class and I have a Tushy class, and soon I will have an egg freezing class as well for you guys to join. There she is. There's Catherine. Okay. Soon here in a second. So you guys sent in a whole bunch of questions. There she is. Hi, Catherine.
Hi.
It's nice to see you. How's it going there in LA?
Good, good. Sorry, I was having some technical difficulties.
That's okay. Can you bring your camera down just a little bit so we see more of your head? You have a very pretty head.
There's a tripod thing. How about that?
That's okay. Yeah, and then it's a little hard to hear you. Let me just see if I can hear you okay.
Can you hear me okay?
I can hear you okay. Are you wearing a headset?
I'm trying to. That also is not working right now.
It doesn't seem like it's working. Why don't you just get a little bit closer to your phone, and then maybe that'll be easier for us to hear you. Can we hear you now?
Are working now. Sorry,
I'm having a hard time hearing you.
Okay, can you hear me now?
Barely. I can barely hear you.
I'm gonna turn off my headphones then.
Okay, that sounds good.
All right. How about that?
Yay! I can hear you. Awesome. All right. Well, thank you guys for joining. We got Dr. Catherine DeUgarte here from Los Angeles. She's my best friend and a fabulous fertility doctor, and all we do together is talk about fertility. So what better thing to do on a Friday at 4 o'clock is to talk about fertility. So here we go. So here's the first question that we got asked, Catherine, and I want to see what you think, and certainly I'll give my input too. So the question is, I went through my egg retrieval, 9 in culture, but only 3 were frozen. So what she's basically saying is she had 3 blastocysts frozen, 2 on day 5 and 1 on day 6. I'm going to get an update tomorrow about day 7, and I heard that day 7 embryos can make a baby. What are your thoughts? So in your hands, what do you tell patients who have embryos that can be cultured to day 7?
So I have had embryos that were cultured to day 7 that have been normal. In fact, I just did it in one of my really good friends recently, and unfortunately did not result in a baby, but it was not a very good quality embryo. So in my experience, I have not had any day 7 babies, but I've had many day 6 babies.
Yeah, I agree. I mean, day 7 quality can be a little bit lower. They take slower to get to that stage, so maybe the pregnancy rate isn't that good, but there are definitely reports of day 7 pregnancies that are really, really good.
Yeah.
Okay, so here's a question about endometriosis. I'm turning 34. I have endometriosis and a low AMH. I had a laparoscopy in 2016, which confirmed the endometriosis. Then I had 2 IUIs, 2 IVF egg retrievals with fresh transfers. In 2018, I moved on to donor eggs. Then in January 2019, I had my first donor egg transfer. It was positive, but it turned out to be a blighted ovum. For those of you who don't know what that is, that means unfortunately it was a pregnancy that was miscarrying. The second and third frozen embryo transfer with the donor egg embryos did not stick. I then went in for a 4th frozen embryo transfer, and it was also a blighted ovum. I then had a DNC. The embryos were normal. I had elevated natural killer cells. What advice do you have? So what would you do, Catherine? And certainly I'll share my thoughts as well.
Well, first of all, I'm sorry for that long journey. That's really frustrating to go through so much, and with donor eggs as well. I'm assuming that they were not tested, or if they were tested, it sounds like the DNC showed normal embryos. I'm personally not a big fan of natural killer cells. I don't think there's any good studies on that. So I'm not a big believer on that. However, I would recommend doing a test called Receptiva that actually Dr. Amy taught me about, as well as the ERA test that also Dr. Amy taught me about, and figuring out if there's a better way to do a transfer properly. Maybe she needs Lupron before, and also maybe reevaluating her uterus, a hysteroscopy to make sure there's no anatomical things. I would also do some other workup for thrombophilias, such as, I believe in MTHFR, and a lot of doctors don't believe in that. But if there is a thrombophilia, I would add a blood thinner and sometimes even prednisone to her transfer.
Yeah, I agree. I would do the same thing. I mean, if you had endometriosis diagnosed on laparoscopy, we know that it just doesn't get better over time, and perhaps addressing that with maybe another laparoscopy maybe Depo-Lupron after doing more implantation testing. That makes perfect sense. Okay, here's another question. I'm 35 years old, going through secondary infertility, trying for 10 months now. My workup showed a day 21 progesterone that was low at 4.7. I also have spotting during my luteal phase. My fertility doctor suggested starting with IUI, but also said that the risk of twins with letrozole and IUI can be as high as 15 to 20% of successful cycles. And my husband and I are terrified of twins. Is that number accurate? What can we do to minimize the risk of twins, considering going straight to IVF because of the risk of twins? What do you good doctors have to say about that? So what do you think?
Well, first of all, I've used letrozole for many years now. I've never, ever had a twin pregnancy with letrozole. In fact, it's known to have just one egg, maybe at most two. So that's very unlikely. I would not quote that high number of multiples. I would say the risks are less than 5%, honestly, with letrozole. In terms of other risks of multiples, obviously it can always happen with shots and insemination. It is worth trying it once if they'd like to. But I wouldn't say to do it over and over again. I say at the most 3 cycles. But I'm not a big fan, if people have unexplained infertility, of using pills. I usually go to shots and insemination.
Yeah, and I would say if someone has a low progesterone, you have to ask, why is the progesterone low? Is it an egg quality issue, right? And so if the FSH is high or the AMH is low, that's a question that you need to ask. And then treating the diagnosis. So if the diagnosis is, lower egg quality, then ovulating 2 eggs would actually be a good strategy to get 1 pregnancy with Femera. So those patients shouldn't be as scared of having twins with Femera. So I agree with you, but obviously whenever you ovulate 2 eggs, if you end up with twins, it's 100% for you. So if that's something that's really not something that you want to do, then doing IVF would make sense. Or maybe if the cost is an issue, maybe consider InvoCell, that little chamber thing. Some people can do that, and that would be a good way, because then you would just transfer 1 embryo too.
So
I think I actually
ultrasounds to make sure there's not 2 follicles before you're doing the insemination. If there's 2 follicles and they're really worried about twins, you don't have to do the insemination or not have intercourse.
Right. I was going to look for my Invo's chamber. It's somewhere in my drawer. I couldn't find it. Okay. Here's another question about PCOS. I was diagnosed with PCOS when I was 24 years old. Since then, I've been on some medication to help me have periods, but no improvements. I want to start trying to conceive soon, and my period is still not regular, making my ovulation difficult to detect. What should I do? So what would you tell a patient who, shares that with you?
So if they're having polycystic ovaries, irregular periods, in those patients, I do think Clomid is a good start, or letrozole, one of those, and ultrasounds to make sure that we don't overdo it in terms of too many follicles. Also, inositol is a good supplement for patients with PCOS, and exercise, acupuncture can help as well.
Yeah. Well, you've heard of my Tushy method, and you've heard of my balls method. And I don't know if you knew, Catherine, did you know I had the Hope method?
Yes, I just heard about it last time we were talking. I love it.
You have a good memory. Yeah. So go through the Hope method, and,
awesome.
Get your levels checked, look at your testosterone, look at your A1C, fix all the things that are in your control. I see someone's asking a question about Ovasitol right now, and I totally recommend Ovasitol to patients who have PCOS, and we'll get to the questions that are chatted live here in a second. So here's another question. A woman who reached out who said, hey doctors, I'm 47 years old. What test can I do to see if I have any healthy eggs left? So what would you tell her, Catherine?
So definitely a follicle count or an ultrasound would be the first step, as well as a day 3 blood test for E2, FSH, and AMH levels to kind of get an idea. But I would be very realistic with her, tell her that unfortunately at 47, I personally have never had a patient at 47 get pregnant with IVF. I have it a 46-year-old with her own eggs, but I personally have never seen a 47-year-old get pregnant.
Wait, you've had a 46-year-old get pregnant and have a healthy baby with her own eggs?
46.
With IVF?
Yep.
Wow, my oldest is 45. I'm a little jealous. I want to hit 46.
Well, she had 20 eggs at 46.
Wow.
It was amazing.
No, I've had 44, 45. I've had 46 to 51 that I've done IVF on that have had a pregnancy, but not quite healthy. So I look forward to that day. Okay.
Yeah.
Here's another question. It is, it's another endometriosis question. So it's someone who has severe endometriosis, had a laparoscopy surgery, also has low ovarian reserve, but just not quite sure how low, but was told it was low, but was told to go right to IVF and not do IUI. So she's asking, like, can't I just try 1 or 2 IUIs? Why or why not?
And how old is she?
What would you say?
How old is she?
35.
35. I mean, you can always, if the tubes are open, anything is possible. You can try as long as the sperm is okay. I just wouldn't try more than 3 tops. Especially, it depends on how many babies she wants to have. If she wants to have 1 baby, then it's fine to try a little longer. But if she wants to have more for the future, it's nice to have embryos on ice.
Yeah, I totally agree with you. If you already have 1 baby, maybe try a couple IUIs. But if you want at least 2, preserve your eggs while you still have healthy ones, because endometriosis can definitely affect egg quality. Okay, here's another great question. It is another endometriosis question. We're getting a lot of those right now.
Yeah.
I found a study that found that endometriosis affects egg quality, just like we kind of talked about right now. Is there any research that shows removing it can improve egg quality, even though it may decrease AMH? And then the other part of the question is, can taking supplements be just as helpful at improving egg quality if you choose not to remove the endometriosis before IVF? What would you say?
I personally am not a big fan of removing endometriosis. I think it can damage the ovary more. I have seen a 28-year-old who had bilateral endometriomas removed, and she went into complete menopause. It was very, very sad. She had come from another outside place. So I'm not a big fan of doing surgery unless people have severe pain. So I usually leave them alone. With that said, I have seen egg quality decrease in patients with endometriosis and have less eggs, especially on the side where there is an endometrioma.
Yeah. And then as far as supplements being as helpful at improving, you know, egg quality as surgery for patients with endometriosis, I think that if there's actually something like an organ, like a cyst that's secreting cells that are inflammatory cells, you know, taking supplements wouldn't necessarily be as helpful as surgery, especially
unless you can get more eggs.
Exactly. So it's kind of like a risk-benefit analysis that you have to do for sure. Okay, here's another question. My transfer is scheduled for next Thursday, and I plan to start progesterone tomorrow. Okay, so transfer next Thursday, planning to start progesterone tomorrow, which would be Saturday.
Perfect. Okay.
My lining at my last lining check was 9.5 millimeters, and my estrogen was 1500, and my progesterone was 0.5. But now, today, this is my second lining check. My lining decreased to 7.5, and my estrogen is 840, and my progesterone is 0.2. Why did my lining and estrogen drop? I'm concerned. Should I transfer or should I cancel? What would you say?
Is she on E2V? Do we know?
That's what it looks like. It looks like she's probably on an estrogen shot.
If she's on an estrogen shot, it can vary because it depends. If you do the estrogen shot, let's say last night, and you do the blood test today, it's going to be higher than if you did it 3 times 3 days ago. So that I wouldn't be so concerned about the estrogen. The lining also, I would ask her if it's the same person doing the ultrasound, because if you and I do the ultrasound on the same person, well, you and I are actually pretty right on with ultrasound.
Yeah, that's true. Right.
Let's say another doctor and us could do the same ultrasound on the same day. We might be a millimeter apart. So, and it also depends on the angle, depends on the bladder, how you measure it. So if she's concerned, maybe I would go in for another lining check on Monday and start the progesterone and maybe not do the transfer if the lining is getting thinner. But I have seen linings go down sometimes.
Right. I mean, my rule in life is if you have any doubt when it comes to an embryo, don't do it. Just wait.
Yeah, if you're stressed out about it, not sleep at night, just don't do it.
Yeah, and the other thing that you can do in a case like that, if your lining's getting a little bit thinner, is start the progesterone, because you're going to have to induce a period anyways. So you might as well just start the progesterone.
Yep.
Right? And then just go back the day before you would have thawed your embryo and just take another look. And if it looks amazing, then go for it. But if it doesn't, just be prepared to not move forward and just use the experience as a learning experience.
And if they have any bleeding, then I definitely wouldn't do it, because I've seen that a few times. People bleed and the lining does get thin, and that's definitely no more transfer.
Right. So now we have a lot of questions that have been added here in our chat. This is a question. Hello, wonderful doctors. How do you grade an embryo on day 3? So what do you guys do in your lab, Catherine?
So in our lab, we grade them basically based on the number of cells on day 3 and the grade based on fragmentation. So for example, 8-cell grade 1 is an A+ embryo versus a 2-cell grade 3 would be a really poor looking embryo. So with the way they look, we don't use other type of grading criteria. Right.
So we look at the number of cells, and then I think of the grade as like, you know, your windshield glass and the tiny little breaks. So that's what the fragments look like, you know, when a rock hits your windshield. And then they basically give you a percentage of breaks inside that glass. And then if there are very few tiny little breaks, then you know it's a grade 1. But if there's more and most of it is fragmented, then it's a grade 3 or grade 4. But sometimes a grade 3 or grade 4 day 3 embryo can turn into a gorgeous blastocyst. I mean, I'm sure you've seen that before.
I had that yesterday.
Yes.
More like grade 3. Today was an expanded blast grade 1.
Isn't that nuts? I know. So you never turn your back on an embryo and you never count it out until the end. So there's always a chance until the very end. Here's another egg freezing question. So egg freezing after age 36, does it work? I've heard so many stories about eggs not resulting in a baby. Thank you. So what's the oldest patient that you've frozen her eggs for her to come back and use them?
Well, I actually have 2 patients right now who froze their eggs at 37, and they were both 41 when they used them, and they're both pregnant now. I have had 40-year-olds eggs that have resulted in babies. I think 40 is the oldest that I've had as eggs.
Yeah, I think me too. Yeah, I mean, I've frozen eggs for women as, you know, I've done a lot of really awesome things. I won't tell people how old the oldest egg I've frozen is someone who is 50 years old, believe it or not. But wow. I've definitely had pregnancies from eggs that were frozen for women between the ages of 39 and 43. So I tell people that egg freezing is for everyone to consider and ask that question. It doesn't mean the eggs are going to work, but I think, you know, men can have kids very easily, you know, until forever. And every woman should have the right and the ability to get her levels checked and see if it's something that she wants to do no matter the chance. So here's another question. Someone asked, it looks like my doctor asked me today if I want to transfer any particular gender or just the best embryo regardless of gender, and I haven't found out the gender of my embryos. I can't really tell what the question is, but Catherine, for you, how do you approach telling your patient gender or not? Because sometimes patients don't realize that gender is one of the chromosomes that we check when we do IVF. What do you tell your patients to do? Best gender or best embryo?
Well, I always tell them ideally best embryo. Just don't look at the gender. Some people don't want to know the gender. And if you have 2 beautiful, gorgeous A+ embryos and you want to pick the gender, you can if you want to. I had a couple today that she wanted to transfer the female and he wants the boy. And so they have to discuss it all weekend and get back to me. But there's obviously pluses and minuses on both sides. So I would say that leave it up to the couple. And sometimes we just have to really, I had to do it out of a hat one time with a patient because they couldn't decide. So we did a little notes in a hat.
We do that too. Catherine, you're kind of disappearing on us. Can you turn your camera a little bit? Thanks. Oh, there you are. Yeah. Can you get a little bit closer? Because you're looking.
My house is going to the ground. It's a very old house.
Shut up. You're a dork is what you are. Okay, here's another question. Couple age 33, husband has motility, morphological abnormalities. I have possible endometriosis, AMH 0.85. Would you recommend keep doing IVF ICSI? What would you say in that type of scenario?
Can you repeat the
first part? It sounds like 33 years old, AMH of 0.8, low motility, low morphology. Would you do ICSI? Or, you know, try naturally? What would you do in that kind of scenario?
I mean, if it's got abnormal sperm parameters, I would recommend doing IVF sooner rather than later. If they wanted to try an insemination, they could, but IVF is going to result in more chance of pregnancy.
I agree. Okay, here's a general question. I'm wondering about Ovasitol. So my acupuncturist recommended it to me, even though I don't have PCOS. What are your thoughts about this and how can it help me? Would you give your patients that?
Yeah, I've seen it work for decreased ovarian reserve as well as polycystic ovarian patients. So I do recommend that as part of my supplement soup that I recommend for patients when they have poor embryo quality.
Yes. Okay, great. Here's a question. This is that same question I asked you about. So gender or embryo quality. And what she's adding is that she has some immune issues as well, like being PI1 heterozygous, having high cytokines, abnormal natural killer cells. And the question is, will my children have these same issues that I have? And should I pick a certain gender embryo so my kids don't have that gender? And I think what she's saying is she doesn't want to pass on, she doesn't want her kids to have fertility is a particular gender more prone to inherit and go through the same suffering as I am. And I feel bad that we even have to think of those things. What would you say to that question?
Well, that's a really good question, but I guess if you had to pick, I would think it's more of an impact on females going through miscarriages than on males and on sperm.
Right. Right. I would have to agree. But I'm hoping that in the next 20 to 40 years, I imagine our kids are going to have kids when they're 50, Catherine.
Probably. Yeah.
Probably. And
Well,
so
I'm freezing my daughter's egg as soon as she graduates from college.
yes. So I'm thinking that in 50 years, hopefully we're going to have more tools on our toolbox than the stuff that we have right now. Here's another great question. Does low ovarian reserve equal poor egg quality? Or is age 35 a better predictor? That's a great question. What would you say?
Great question. There was a study many years ago looking at age versus FSH levels. And what I call it is women over 40 with a high FSH is the double whammy, basically. So that's the really bad scenario to be in, unfortunately. But if you're younger.
Double whammy. Ouch, Catherine.
I know.
Ow.
Oh, I see it. But if you're younger with a normal FSH versus older, I'm sorry, if you're younger with a high FSH versus over 40, I mean, I'm in that crowd. I'm 46 now. But if you're older than 40 with a normal FSH, so the younger person will do better than the older with a normal FSH.
Right. So what drives me nuts is when patients come in and they're told, let's say you're 35 years old and someone has told you have the eggs of a 45-year-old. There's no such thing. A 35-year-old has 35-year-old eggs, right? I mean, even if you have a lower quantity of eggs, your eggs will actually behave a lot better once fertilized by sperm. Right. So I think that's really unfair to tell someone, and some people don't choose to be as aggressive as they could possibly be with IVF or other treatments because they're made to feel like they're basically menopausal at a time that they're not. So find Catherine and I. We'll get out our pom-poms and do whatever we can to help you. Okay, here's another question. Anything patients with unexplained infertility can do at home to help boost IUI success? So what would you tell someone who asked you that question?
Sex?
Not sex. I didn't say sex yet. It's not 5 o'clock yet. No. Oh my God. See how gullible I am? Sex. Oh, Jesus, Catherine. Okay. Yeah, sex.
So yes. So
see, my sister always tells me that I don't like talking about sex. See? You're talking about sex. That's true.
I am talking about it.
I know. I mean, we talk about it all day long. I just like to tell people.
Obviously, they're not a same-sex couple, but even if they're a same-sex couple, I think sex still boosts orgasm and improves sperm arriving to the eggs as well. So either way, I think it helps. But definitely when I do inseminations, I recommend for patients to have intercourse the night of and then the day after.
You're disappearing again, Catherine.
I'm disappearing? I don't know why I keep disappearing. That's so weird. Let me move my chair up.
I think your chair, there you go.
Keeps going down,
I think you need to get your chair. You're killing me over here, Catherine. I think you need a chair. You're disappearing. It's like you're sinking into the ground, woman.
I think my house has quicksand in it.
It seems like it. Yeah, I agree. Have sex. I mean, I think patients come here and I'm like, you have to have sex. And they like freak out at me. Well, when I did the semen analysis, I was told that my husband had to abstain for 3 to 5 days. And I'm like, this is different. You want to get pregnant, like have sex. Okay. Here's another question. Are there any indicators that a patient would need an ERA test or a Receptiva test before completing a cycle of IVF? What would you say?
Well, I know Dr. Amy's a fan of doing that before doing her first transfer. I personally don't do that in patients right away, unless they only have one golden embryo that it took them 3 cycles to get to. But if they have 5 or 6 embryos that are normal, I think it's not a requirement for my patients. We can try a transfer, and if it doesn't work, then I recommend it. But I know we think differently on this one. I think this is the only thing we do.
Well, I'm going to put you on the spot. What if your patient had 1 female embryo and the rest were male? Would you think of that as the golden embryo and maybe recommend it before? And let's say the female embryo happened to be the best quality one. Because I feel like people sometimes go through their best quality embryos until they figure out what they need to do. So doing it first, would you change your mind based on that?
I mean, if she really, really wanted a girl, eventually I would say put the boy first, so he can be a practice embryo, and then keep the girl for later. But if she really, really, really wanted the girl, yes, we could do the ERA first.
Got it. Okay. What grade is the best embryo you recommend transferring? I'm going to change this question around. Have you ever transferred an embryo that is CC quality, which in my lab is the worst quality, and see it turn into a healthy pregnancy? Do you guys?
Sure.
You do?
Yep.
Yeah. Do you freeze CCs? I mean, every lab has different, grading criteria. In our lab, we don't even biopsy and freeze or transfer CCs but you know, maybe it's a different definition in your lab.
So yeah, we use a different grading criteria. So I think I always talk to the patients, if they only have one, for example, expanded blast grade 3 embryo, nothing else to freeze, I talk to them about it, and most will want to freeze it. I probably wouldn't recommend genetic testing if you just had that.
Right.
But if you had 3 embryos that you're freezing and you have that one bad looking embryo, might as well just throw that one in the mix in the freezer with its friends.
Got it. I like that, with his friends. Okay. I was deemed to have PCOS. I don't, one second. Okay. I was deemed having PCOS, but it appears from ultrasound I don't ovulate. Is that accurate? I think that the question is, I'm not sure what the question is, so I'm not going to embarrass myself.
I think they mean that they took, maybe they have PCOS and they looked at the ultrasound and they never had a follicle that grew.
Maybe.
In which case you could take medications to try to make it grow, but some people are very resistant to medications.
Yeah, that makes sense. Okay. Catherine, this is a question for you. What is your supplement soup?
My supplement soup is probably very similar to your supplement soup, and we can email it to whoever wants it because it's kind of exhausting. But the most important thing from my supplement soup is CoQ10, which I recommend 600 per day. I also like to use, again, like we talked about, Ovacitol, DHEA in some patients, melatonin, royal jelly, vitamin C, E, D if they need to. There's pycnogenol. There's quite a few other ones on there, but those are the most important ones. And I kind of individualize it based on the patients.
Great. And then that last question about the PCOS, what she's saying is I do have regular cycles, but they said I have PCO appearing ovaries on ultrasound. Like, do I have PCOS? Right?
So that's a good question. But if you just have polycystic looking like ovaries and you have a normal testosterone level and you don't have hair growth on your face or your body and you don't have irregular periods, you don't have polycystic ovarian syndrome, you just have polycystic looking like ovaries. So you treat them as if a patient with polycystic ovaries, you give less medications, but you don't treat the person as a PCOS patient.
Right. You don't want to overstimulate that person, but they're just lucky to have a lot of eggs. That's how I think about it. So 15% of women can have PCO appearing ovaries without having PCOS. Yeah.
Right.
Okay, here we go. I have PCOS. Is a long or short protocol better for IVF? What do you guys do?
Definitely short protocol antagonist, because I think Lupron protocol could definitely hyperstimulate somebody with PCOS, and you can't do use Lupron trigger.
This is like a game of would you rather. Would you rather this or that? We're on the same page. Yes. Okay, what's the minimum wait time between IVF pregnancies? So what do you tell your patients between deliveries and when they can get another embryo home?
It depends on their age, but I say ideally a year would be great, but 6 months is the least amount of time.
Okay, you're very nice. I'm not that nice. I say 12 months, just like you said, for a vaginal delivery, 18 for C-section. What do you say for C-section patients?
For C-section patients, again, I think a year is ideal.
Ideal, yeah.
And I do want to make sure that we do a fluid ultrasound to make sure there's no scarring beforehand.
Totally. Okay. Any considerations for a BRCA positive patient considering fertility treatment? Any risk to the ovaries or considerations in your treatment plan? What do you do for your patients who are BRCA positive, Catherine?
So I recommend doing genetic testing on their embryos so that their daughters, you know, you can actually select the normal embryo so their daughters don't go through the same thing that their mothers do. Also recommend that once they have completed the number of embryos that are needed in the freezer, then they should consider getting pregnant and doing, depending on their doctor's decisions, either a bilateral oophorectomy, removing the ovaries as well as the fallopian tubes, and you know, bilateral mastectomies in some patients depending on their family history and their age and how many babies they want to have.
And do you take a different approach when you stimulate them as far as estrogen exposure, and different approach when you're doing a frozen embryo transfer?
If you're positive and no breast cancer currently, I don't do letrozole. I don't do that for my breast cancer patients.
Got it. Yeah. I mean, I add letrozole every day just because I can, and the side effect profile is minimal. And then for the transfer, I also do the same. I add letrozole up until the progesterone start date too, because that helps reduce the estrogen level. Here's another question. Progesterone, vaginally or orally? Which one's better when trying naturally? Which
Definitely not orally. I think orally is like basically taking placebo.
What? No. Really? Okay, you tell me your thing. You do your thing and I'll tell you mine. So you think Okay, tell me your thing.
So I think vaginal progesterone is much better absorbed for patients trying to get pregnant. I think oral progesterone is great for postmenopausal women, just as a supplement, but it has a lot more side effects. And I don't think it works as well for fertility reasons. Obviously, in terms of IVF, I prefer the shots over the vaginal because I think they do work better.
Yeah, I mean, I tell patients oral is just as good as vaginal. Oral will make you feel drunk and dizzy. Vaginal will give you that disgusting discharge. Just don't place your vaginal pill orally.
After we use it.
There you go. Okay. Yeah, I give my patients the option. Some patients don't want to place it vaginally, and you know, I would take it orally if it were me, but I hear you. Maybe I'll change my recommendations now. Okay, any recommendations on brands for DHEA? What do you tell your patients, Catherine?
Theralogic is a good brand. Designs for Health is what I've been using lately, and they're a really good company as well. You got to be really careful with Amazon because Amazon gets products from certain countries that don't keep good storage, and you got to be really careful. Whole Foods is another good place to get it from, or just compound pharmacies.
For those of you who are watching this, Catherine just said Theralogics. And if you use the PRC code TUSHY, capital T, capital U, capital S, capital H, capital Y, all caps TUSHY, you'll get the PRC price. So there's a PRC discount on there. So if you want to do that, you can. Okay. Speaking of sex, whew, is it 5 yet? No. Should we refrain from sex? Thank you. Oh, that feels good. Yeah. Thank you. Should we refrain from sex leading up to transfer or after transfer? What do you tell your patients? I'll tell you what I say.
This is where we also
okay, tell me.
So I do say 2-3 days before transfer, I'm okay with them having sex. The reason I don't like them having sex the day before the transfer is that the sperm can stay there for a while. It can flush out that embryo. After the transfer.
Wait, where is the sperm flushing out the embryo? Where is it going to flush it out?
Sitting in the tubes. It's sitting in it lives for 72 hours. So I think it's not a good idea to put sperm in there before.
Okay.
Like we don't like doing transfers when there's fluid in the uterus.
Okay.
So I don't recommend it before the transfer. After the transfer, again, I like them to just rest in same reasoning, and for 10 days afterwards. I also think that sometimes if people have intercourse and they have pain, or they're taking vaginal progesterone, and then the guys get it all absorbed, and then it's a hold, and they get stressed out about it. So I say not till pregnancy test, personally.
Yeah, I mean, I definitely tell them to stop between the transfer and the pregnancy test, and with a good positive pregnancy test, they can resume. But that's interesting. I haven't heard of that perspective about sperm sitting there, and somehow I have a sperm cell right here, somehow like fighting or interfering with an embryo implanting. Okay, can you estimate the age of menopause from the AMH test? What do you tell your patients?
You can never estimate the exact age of menopause, but you can tell if somebody's going to go into menopause earlier than other people their age, if their AMH is low and they have a low follicle count. But I have seen people with low AMHs have multiple babies, and I've seen people with high AMHs basically go into menopause very quickly. So it's rare. It's rare that would happen.
Mm-hmm. Yeah. Here's another question. Thank you for that. Is sex during stimulation okay? So do you tell your patients it's safe to have sex during IVF?
And I think, again, we differ here as well. I tell them the first 3-4 days while they're going through their shots, it's okay. The reason I don't like them to have sex after 4 or 5 days of the meds is because the ovaries get bigger, and I worry about them having torsion and twisting their ovaries, and also for patients who are freezing their eggs. What if they have a runaway egg closer to the retrieval time? They could actually get pregnant. I've never had that situation happen, but in theory, it could happen.
Okay, so I say you're right. It's okay to have sex up until the egg retrieval. Actually, I tell patients not to, basically, sex the night before the trigger shot is safe. And then after that, I say no. But always listen to your body. If you're swollen and you feel super bloated, don't do it. And obviously, there are a lot of people who will feel that way, especially if you have double-digit eggs. Here's a great question. Do you recommend thawing an untested blast to do PGA testing, or is the risk of harming the embryo too high?
If it's just one blast?
Or any blast. Like if you have untested, let's say you have frozen embryos that haven't been tested, do you recommend testing them? And I'll tell you what my algorithm is, but what's the decision tree that you use to tell a patient whether it's okay to thaw untested frozen blasts?
I think it depends on the patient, depends on what the outcome goal is. If it's a patient that would not feel comfortable terminating, if it's an abnormal pregnancy and they really want to avoid a miscarriage and termination, then I would do that. But if it's only one embryo, I probably would not. I probably would just go ahead and do the transfer without testing it.
Yeah, I agree. I mean, I think the quality of the embryo really determines whether you should do it or not. And then if you have an IVF lab that really doesn't like doing it, then you don't want to do it. It just means they don't feel as comfortable with it, because it is harder for the embryologist to thaw and biopsy an embryo that was frozen. They don't really like doing that. But if they're really good at it, then they don't mind, you know. So just do what your doctor thinks is best for you. And it shouldn't risk harming the embryo unless it's a lower quality embryo. So not every embryo should be biopsied.
And I've had that situation several times when people freeze their embryos and then unfortunately they have a miscarriage, they don't do genetic testing, and then they really don't want to go through another miscarriage, so we unfreeze the embryos, refreeze them, and I've had several babies that way, healthy babies, with patients doing that.
Right. So someone asked, is ubiquinol good? And you and I both know that yes, it's another form of CoQ10 and it's totally fine. How do you define low ovarian reserve? So what, you know, how would you tell if someone has low ovarian reserve or not, Catherine?
And it also depends on the patient's age. If somebody is 40 with one follicle, obviously that's considered low ovarian reserve. If somebody's 45 with one follicle, that's probably pretty good. So I think it depends on the age and depends on follicle count as well as AMH. Am I sinking again? Really? This chair. I got to get a new chair for next time.
Well, I might fire you for next time, but
I know you're just gonna have to fire me, I think.
I'm not going to.
So, but it's more exciting, right? I keep going away.
It is way more exciting. Absolutely.
I'm trying to leave.
You're killing me.
Anyways, what were we saying?
Ovarian reserve.
Ovarian reserve. So AMH, E2, FSH, and ultrasound, and then we make a decision. But never say never.
Never. Ever say ever. Okay. I'm 34 years old. My AMH is 0.3. I've gone through 4 IVF cycles. The last embryo that I had, I got one and it was mosaic. Would you transfer it or keep doing IVF? What would you say?
I have transferred low mosaic embryos. At this point, I don't have any babies that have resulted from mosaics. I haven't done a whole lot of transfers of low mosaics because most people who've had low mosaics have had other normal embryos that we've transferred instead. But complex or abnormal high mosaics, I would not transfer.
Yeah. And the question of like, keep doing IVF or not, I mean, after 4 IVF cycles, you have to ask, like, have you reached that point where you're like, I'm ready to move on? You know, so that's a very personal question. So there are some patients who would do 2 more cycles to see if they could even get 1 or 2 normal embryos. But if you feel like you're done, try that mosaic. I've had lots of live births from mosaic embryos. I've been doing mosaic transfers for quite a while now. Before even the embryo testing companies were telling us that they were mosaic, I asked them to give me those results, and they were so uncomfortable with it back in the day that they would only call me with the results. They wouldn't put it in the report. Isn't that nuts?
Okay. Yeah. And have you had from the high mosaics as well, or just the low mosaics?
Just low mosaics.
Low mosaics.
Yeah. I don't even think I've transferred a high mosaic yet.
Yeah.
I've only transferred low mosaics.
Right.
Okay. How do you know you have PCOS? What do you tell a patient?
So I think we went through the criteria before, but basically if they have irregular periods, polycystic looking like ovaries, high testosterone levels, or hirsutism or hair growth, you have to have 2 out of the 4 criteria to make the diagnosis of polycystic ovaries. And again, you just treat them differently. Yep.
Okay. I just wrote down the email address of the person who's asking you for your supplement soup. Okay. So I'll send it to you.
Sounds good.
If you are planning a natural IUI cycle, when should you have sex aside from the scheduled IUI? What would you tell a patient?
So I actually did a little bit of research on this when I wrote a chapter for a book for Dr. Rapkin, actually. And what I found is that if people have 28-day periods, I usually recommend starting on day 10. I usually tell people have sex whenever you want to. Pretend you're not just having sex to make a baby, because otherwise you take the fun out of it.
I don't know who's having sex for fun, honestly, Catherine.
No,
people still do that? Really? Okay.
So I think people should always be doing that.
Yeah.
And then in terms of starting on day 10, I think people should have sex every 2 to 3 days. I think that would be good. And then when ovulation happens, when the ovulation kit turns positive, I usually say that day and the next day, like 2 days in a row, if possible, would be good. Because what I find, otherwise people have sex every day. And then by the time ovulation happens, they're too exhausted to have sex.
Right, right. It's very true. So sex is good. Thank you. Okay. I'm 43 years old. I've done 5 IVF cycles and only 1 normal embryo. First of all, that's amazing to be 43
awesome.
and have a normal embryo. Like, wow. I have an endometrioma. Would you recommend that I have surgery to remove it or not before the transfer? What would you do? How would you make that decision?
Definitely not before the transfer, unless, again, she was having severe pain and it was very big and it might have an issue in pregnancy. If it was like a 10 centimeter one, maybe. But if it's a 3 centimeter endometrioma, I would leave it alone.
Yeah, and then also do the receptiva test and see if it's causing inflammation, right? So if it's causing inflammation in the lining of the uterus, you're going to know that. And if your BCL6 score is high, I did an interview with Dr. Bruce Leslie. He's the one that discovered BCL6 inside the uterus to kind of give patients a score and then tell us how to adjust the protocols. That would be an important test to do. Here's a question about PCOS. Is high prolactin associated with PCOS?
Absolutely. And if you read Spiroff, which we all did in fellowship.
I have a copy right in front of me, actually. Yes.
I think it's sometimes in some patients a third. It's a third,
yeah, 30%.
I remember.
Yeah.
Sometimes a third of patients with PCOS have a high prolactin. It's pretty high. I don't see that in my practice, honestly. I think that's a Spiroff thing, but I have seen that, and also high prolactin is associated with high thyroid. So if your TSH is abnormal, a lot of times the prolactin will go along. But also if people have sex today, back to sex, sorry. People have sex today before the prolactin level, if people are in fasting, people are exercising a lot, people are having a recent pregnancy, they can also have a higher prolactin level.
Yeah, this is a great question about drop-off rates. I call it the IVF attrition rate, and it's different for everybody. What is the drop-off rate approximately from egg retrieval to fertilized mature egg to day 5 blastocyst to PGS testing on average? So let's just give you a scenario. So someone is 35 years old with 10 mature eggs at retrieval. What would you tell them they should expect at 35, 10 mature eggs to get from egg to blastocyst to normal embryos? What would you say?
So in general, I say it's a 50-50-50-50-50 rule. So if you start out with 10 eggs, I mean, in general, you'll have 50% of them that will make it to day 3, 50% of those that will make it to day 5, and 50% of those that will be normal. I would say in general, with 10 eggs, you'll have, if you do ICSI, about 8 of them fertilized. If you do IVF, about 7%, 7 of them fertilized. So
yeah, I agree with that. Is there ever a scenario where progesterone shots are not needed?
Yes, when vaginal works. So absolutely.
When vaginal, yeah, totally. I mean, I think sometimes when people listen to us talk about progesterone, they think that the shots are for IUI patients. And I actually do have IUI patients that prefer the shot. Do you?
Right. I have actually patients in general who prefer the shots over the vaginal mess.
Yeah. Yeah.
And it's less expensive.
Yeah. I call it a Vagiseltzer.
Vagiseltzer. I like that.
And if you place blue pills in your vagina, Smurfgina.
Right, Smurf. Yeah, I call that Smurf.
And then you can turn your vagina into a pharmacy, and then it becomes Pharmgina. Pharmacy, vagina. Okay.
Although one of my patients called it vanilla milkshake.
Vanilla milkshake. Yeah. I don't think I want to drink a milk. I don't drink milkshakes anyway. But yeah, that is true. It's like a vaginal slime. Okay, moving on. This is a great question. Is it common to only retrieve immature eggs with PCOS?
It's true that people with PCOS have a higher percentage of immature eggs, but not all of them will be immature. But usually people with PCOS have a lot of small follicles. So yes, they'll have a higher percentage of immature eggs.
Okay, here's another question about endometriosis. Is silent endometriosis common? And when is it recommended to test for it when there are no symptoms? What do you do for your patients?
So there's a study, a lot older study that showed that 30% of patients that present to an infertility doctor have endometriosis. And a lot of those don't even know about it. With that said, I don't recommend doing laparoscopy. I think when I was a medical student, they used to do laparoscopy for everybody, but they don't do that anymore because it's invasive and we have IVF as a tool. So I don't recommend checking for endometriosis for everybody unless they have severe pain or failed cycles.
Yeah, I think we might have trained around the same people. I literally was telling someone that today, like you came in for your new patient appointment, you would get booked immediately for your pre-op, for your laparoscopy to see if you had endometriosis. Totally. Yep. And now we just don't do that. But silent endo is very, very common. And that's why I use the receptiva test. And I think it's confusing because there are people that have no symptoms. And then you look at their uterus and you're telling them how everything's beautiful and you just don't know they have endometriosis until you do that test. Okay, here's another question. When do you recommend your patients should start taking progesterone vaginally? So what's your protocol, Catherine?
So I usually recommend for IUI patients.
Yeah.
Or
Or
5
just
a.m.?
even not IUI. Like I tell patients, you know, progesterone's like water to a marathon runner. As soon as I meet someone, I'm like, start taking it even when you're trying naturally. And then there's that PROOV test, PROOV test.com, that looks at progesterone and can confirm ovulation and even tell you if it's low. What do you tell patients?
So I don't like progesterone for everybody because it's just the mess and the side effects. Some people get really bad bloating. Just one of my patients are really depressed on progesterone.
Right. So then you would
I
stop
don't
it. Totally. I agree.
recommend it for everybody. And when I do inseminations, I usually don't do it on the first insemination unless they have a history of a short luteal phase or recurrent pregnancy loss. But when I do IUIs, I do start it 2 days afterwards for patients who haven't gotten pregnant the first one. And for vaginal progesterone for transfers, I usually do the transfer on the 6th day of progesterone.
Got it. Got it. Similar to what I do. Here's another question. 41-year-old just did her first egg retrieval, has an AMH of 9.57. Holy smokes. Wants to have 2 children.
Okay.
And I can't tell what the question is. What would you recommend? She just did
So I
her
would
first egg retrieval. She wants, that's the question. I can't
not
believe I
to
didn't, it's
stress
just
out.
staring at me. What would you do, Catherine?
It's a great situation.
Yeah.
High AMH, just be very careful on the medications because
Yeah. So how many egg retrievals do you think someone like that would need to do if she wants
for
2
babies?
children?
Well,
Yeah.
it also depends on her age.
She's
So
41. She's
Oh,
41.
41. I missed that part. Okay. So, and also depends on her follicle count. I want to know that. So I
Well,
think
her
that's
AMH is 9.5. So let's just say her follicle count is 15 to 20.
15. I think given her age, she may have to do 1 or 2 retrievals to get to.
Yeah, I agree. Okay. When do you recommend a frozen frozen transfer, natural versus medicated? Would you rather a natural cycle transfer or a medicated transfer?
Great question. Had that discussion yesterday with a patient. So I'm a bigger fan of medicated transfers because I think you can time them perfectly and also you can control the amount of hormones that go in. When people have their own egg that ovulates, you don't know how much estrogen and progesterone that egg releases, so it's not very well controlled. With that said, I have patients with migraine headaches and people who can't tolerate estrogen. People who want to do things more naturally that we've done natural cycles on, but you can't time them exactly. So for patients who are traveling, which not now, but in the past when people traveled, we had to plan, you know, specifically for a Friday transfer. Now doesn't really matter, so it's less of an issue.
Right, right. Okay. What do you do to prevent OHSS in your patients?
So I love Lupron trigger. That's been one of my favorite things since graduating from fellowship, because when I graduated from fellowship, we did not have Lupron trigger in our medication drawer. So I think that's really, really changed how people feel afterwards. So definitely Lupron trigger with or without HCG, depending on the patient.
Mm-hmm.
I also recommend, you know, for patients with a lot of follicles, not starting on very high dose of medications. And I check blood tests to make sure that we don't overdo it. And sometimes doing Dostinex or, you know, carbogoline afterwards to make sure that people don't get hyperstimulation symptoms if they're very high risk.
Absolutely. And take Femara. I sometimes restart Femara, not restart, but I start Femara on the night of the trigger shot, maybe for 1 to 2 days to even 7 days. And sometimes even restarting the antagonist. So taking Cetrotide or Ganirelix maybe for 7 days too. I mean, it's a lot of money to do all that stuff, but those are things that you can do as well. Here's another question. What would you do for a patient who had PCOS, had 1 miscarriage with an IUI and 1 chemical pregnancy naturally? Should I go natural or, and not do any fertility treatments? Well, let's just talk about that in general. Someone with PCOS who's had a miscarriage, or actually 2 miscarriages. I think of a chemical pregnancy as a miscarriage too. Right. So how would you guide someone who's had that?
So I would do a workup on her. I would make sure she has an HSG to make sure there's no polyps or fibroids. I would also do a blood test to make sure there's no thyroid issues, prolactin issues. Again, you could go on the thrombophilia pathway, which is very controversial. But you could check for those as well. And if nothing is found, you could offer genetic testing with IVF if she really didn't want to go through another miscarriage. And progesterone and aspirin, I'm a big believer in it. I know some people aren't, but I would, for the next pregnancy, if she didn't want to do IVF, I would do progesterone 2 days after ovulation. Sometimes that helps.
So I've come up with something I call the angel approach or the angel method. So, you know, for patients who, sorry about that, guys, oh my gosh, that's annoying. Maybe it's time for us to stop, Catherine, but we have so many more questions That honking is very obnoxious. I'm sorry, you guys. We'll just wait for a second.
It's not somebody stealing your car, is it?
No, they can steal it. It's so old. It's
Okay.
fine. My car is 12 years old and they can have it if they want it. Oh no. Is that annoying,
We
Catherine?
can go past the noise. We're bigger than that.
Really? Do you think people, hey, for you guys who are watching, should I keep talking or do you want me to show me some hearts? Oh, there we go. Okay, so I call it the angel. Yeah, so I tell patients who've had that, I say, I'm going to take the angel approach with you. A is for autoimmune and age. So look at the AMH and do the autoimmune panel like antiphospholipid antibody syndrome and anatomy. So those are the 3 A's: anatomy, autoimmune, and age. So think of those 3. The N is nutritional deficiencies.
Mm-hmm.
So make sure you're getting enough folate, taking a really good prenatal. And someone asked about my favorite prenatal and yours. So we'll talk about that in a second. The G is genetic abnormalities,
Mm-hmm.
right? So look at chromosome analysis, DNA fragmentation testing, carrier screening, all that kind of stuff, fragile, stuff like that. The E is endocrine abnormalities. So looking at your TSH, do you have a high hemoglobin A1C? And then the L of the angel method or the angel approach is lifestyle, heavy drinking,
Right.
obesity, smoking, THC. I mean, we know from very good studies that THC is not good for pregnancy. And even if a woman doesn't smoke weed or, take it in a gummy bear form, whatever they do, and the male partner does, his exposure can increase that woman's risk of having a miscarriage. And I think it's probably because of DNA fragmentation. So that's the method. So I came up with that. I was like, I don't want this to be confusing for patients anymore. Like, I want them to know, like, these are the steps you do. It's very straightforward and you just get it done. And we do it.
I like that.
Why, thank you.
You're an angel.
Oh, no, you're an angel. Okay. Let's see here. Prenatal vitamin. What's the prenatal that you recommend, Catherine?
So again, I don't think it really matters as long as you take it. Because if I'm going to recommend a prenatal vitamin that's this big horse pill that you're not going to take, then you're not going to take it. So as long as, even in some patients who can't tolerate big pills, I say just the gummies. Gummy prenatals are good.
I just said gummies are bad. And now you're recommending gummies?
Not gummy marijuana is bad, but not gummy prenatals. Make sure that you don't give the wrong gummies to the kids. Because apparently that happened in LA. Somebody had told me about a party with the kids ate.
Oh no. Okay.
Yeah.
Wrong gummies.
Wrong gummies. So in terms of the prenatal, if they have miscarriages or MTHFR deficiency, MTHFR is important to get a methylated folic acid. Again, I think Thorn Prenatal has one. Designs for Health has a methylated folic acid in it. So I think that's important for those patients.
Yeah, I like this. The prenatal that I like is orthomolecular prenatal. I think it's awesome. Our thread or our chat is blowing up with everyone emailing their email addresses I have to write this down because once I end our call, all these messages are going to go away. So Catherine, I think we need to do this again. Do you know we've been talking for almost an hour right now?
Have we really?
We really have. And I feel so bad. It's like we have these amazing questions. What are you doing next Friday?
Hanging out with you, apparently.
And getting
a better chair. I figured out my tripod situation. I'm not sinking anymore. Do you notice? Am I still sinking?
No, you're not.
Oh, look, I figured out my tripod moves. Okay.
Oh my God, you're killing me. So you guys, thank you all for joining. I actually have a 5 o'clock patient. So I don't want, I hate waiting for other people and I don't want to make her wait. And so I'm just going to take down a couple of more of these emails right here. And then, we've probably had another maybe 15 questions that were added to the chat.
We can do that next time.
And we'll definitely do it next time. For everybody who added a question here, and I have 1, 2, 3, 4, 5, I have 7 emails. Wow, here's another one for Catherine's supplement soup.
Well, it's our supplement soup because we came up with it together.
That's true. That is true. That is true.
We keep learning about different things. And
yeah, that is true. So for those of you guys who have questions, and I see lots of great details that people are adding here, and I feel awful because you and I could literally, we literally could do this all night long, but we're going to sign off right now. And then you and I are going to find you a good chair.
And we're gonna cook our soup together this weekend, and we'll
email it out to everybody.
Email you guys the new Amy Catherine soup.
Amy Catherine soup, AC soup. We'll have to get it branded. Okay, last
Come
email.
up with a soup protocol.
Soup
Supplements.
protocol. Okay,
Yeah.
well, thank you guys for joining us. I hope you guys have a wonderful weekend. Sending everyone love. And last email I'm going to write down, and then we'll sign off here. Okay, well, thank you guys.
All right,
Thank
we'll
you for
talk
joining
soon.
us.
Bye, everybody. Stay
Okay,
safe.
love you.
Take care.
Bye, guys.
Bye.
Bye-bye.
Bye.
You're welcome, everyone. Thanks for joining.